my disclosure. Let me show to start with this topic with this case. In this case, I personally failed antegradely and retrogradely with a puncture of distal AT. It's a diabetic patient with a gangrene in the fourth toe, and this is the baseline angiography. You can see the only one vessel, peroneal vessel, reaching the ankle level. There is no stump for posterior tibial artery, and we can imagine just a little bit the anterior one. The foot was like this with the this tract of a pedal artery, exactly the one I tried to perform the retrograde puncture that failed for a rupture of the artery, and a suspended tract of medial plantar artery in the forefoot, in the rear foot. Sorry. So next time I tried directly to perform the puncture of the medial plantar artery. This is the puncture. Ask the patient to lift the forefoot to straighten the curve. This is a V18 wire with a loop in a subintimal dissection rotated in order to maintain the loop as smaller as possible. You can see the calcification of the vessel, and supported with a CXI catheter. We arrived finally to discover that there was a high origin of the posterior tibial artery. You can see the wire proceeding the dissection. There is a stent, so leaving as a marker the CXI catheter close to the supposed origin, it was possible with an antegrade Bernstein and a new a V18 wire to go down to snare the wire from below, as normally we do, and we saw Andre doing so many times. So after snaring the wire, it was possible to advance the Bernstein catheter to the heel. I failed to recanalize the medial plantar artery because I had another rupture, so I was obliged to recanalize the lateral plantar artery. You can see the dissection of the lateral plantar artery, and when I arrive very close to the transition area with the arch, it was not possible to advance the dissection. So I was obliged at this point to perform a retrograde distal puncture of the second transmetarsal artery like this, and through the puncture it was possible to advance another V18 wire, and it was possible to re-enter in this way. So a new snaring from the posterior. You can see the same system, and it was possible to finally dilate everything. You can see the flow in the posterior. Very good, and the patient is moving now, so the next one should be better. You can see the direct flow into the forefoot, but what is important is that clinically, okay, this is the final result, and clinically immediately there was an improvement in the critical limb ischemia. It was possible after the demarcation of the wound. We assisted at a very high improvement of TCPO2. It was possible to perform the amputation, and the patient is going well. So these procedures are a little bit amazing, but you can see this is a presentation of Urosawa. He called this insane procedures, but they start to perform these procedures in Japan too. So I don't know if they are insane, maybe, but they are useful. So our indication were resumed by the case. So after a failure, an antegrade recanalization failure, or when we do not have any target distal vessel like pedal artery or distal posterior tibial artery, is possible to perform the puncture in the digital artery or or meta-tarsal artery, more correctly. So the technique is schematic. We have to stick the artery, we have to wire the artery, and then we have to retrogradely recanalize the main tibial vessel, and at the end the angioplasty in order to perform the hemostasis. The first trick is to correctly expose the foot to the X-ray. So we use the two projection, the anteroposterior and the lateral view, in order to evaluate correctly all the artery of the foot. The puncture is performed with a 21 gauge needle, dedicated needle, and previously it's very important to inject dilator as distally as possible with the Bernstein French from a popliteal artery and in the area of the local anesthesia, which is mixed with vasodilators too. We use for sure calcification as target of our puncture. When possible, we use ultrasound, and we can help, we can ask for a growing injection of contrast medium to see the artery when we do not have calcification. It's very important, as Andre Schmidt showed us, the alignment of the needle with the artery in order to perform properly the puncture. Is very important to have a needle with a very short tip, because sometimes the hole of the needle is bigger than the artery, so it's easy to go out of the artery with the wire, and that's why we use this very short needle. When we have to wire in the digital branch, is probably the most delicate phase. So we have a floppy, soft tip in the wire, and if we want to insert a support catheter or directly a balloon or a microsheet, we have to insert the stiff part of the body of the wire. So it's important to park the tip of the wire in the first branch we can find, in order to have 1 centimeter, at least 1 centimeter or 2 of the body, the stiff body of the wire, into the artery, in order to support our microsheet or our directly our support catheter, microcatheter, or direct balloon. So you can see here, in this case, how poor was the flow. This is the puncture of the digital. This is the wiring. You can see here the wire, the tip of the wire, parked in another digital artery in order to have the stiff part inside. So it was possible to insert a CXI catheter and retrogradely recanalize the posterior. And at the end of the procedure, this is the very short balloon, single marker, advanced into the digital artery in order to seal the access. This is the final flow, and in the anteroposterior view, you can see we have a little bit of bleeding, but it's enough to put a wire on the access. So the retrograde recanalization, we already have seen this procedure with the snaring is quite simple, and we use for sure long balloon for the final dilatation and the short balloon for the hemostasis in the digital artery. So in conclusion, we used to consider this kind of procedure as a rescue procedure when we had problems, and consider the retrograde techniques when there are the right anatomical condition, of course, and to conclude, the retrograde distal approach combined with all the other advanced technique could improve our success rate in CLI. Thank you very much for your attention.